Hi everyone, and in this video I'll be discussing drugs used in myasthenia gravis. Now we are discussing this topic because it's an application of ANS pharmacology, particularly the cholinergic system. Now what is myasthenia gravis? It's an autoimmune disorder. 1 in 10,000 people are affected with this. So here the problem is the antibodies are produced against the NM receptor, that is nicotinic receptor, particularly the neuromuscular junction is affected here. The problem here is the acetylcholine cannot function fully. The muscles cannot work efficiently. So the patient will have weakness, particularly the eyelids, the extraocular muscles, the facial muscles, the pharyngeal muscles are affected. And as the disease progresses, the other muscles get involved. So basically, myasthenia gravis is an autoimmune disorder. Let us see what are the drugs used in that. Now to understand that, I have taken a case-based approach. So we'll take a MCQ and based on that, we'll come to the answer later. Mr. Swami, aged 38 years, he comes to the OPD with the complaints of drooping of eyelids, difficulty while chewing food, and weakness of upper and lower limbs, which fluctuates in intensity over time. He was diagnosed as a case of myasthenia gravis. What is the drug used to diagnose this condition? Rivastigmine, edrophonium, physostigmine, malathion. So let us understand, because here already diagnosis is given and it is diagnosed with myasthenia gravis. You can see the muscle weakness, and the weakness increases as the day progresses. So let us understand the pathophysiology, then we'll understand what are the drugs used in the management and what are the drugs used to diagnose myasthenia gravis. So what we are going to discuss is myasthenia gravis. So as I already told, it's an autoimmune disorder. That means the antibodies are produced, so we call them as autoantibodies. So the autoantibodies are produced against the receptor N, that is nicotinic. So the antibodies are present against nicotinic receptor, particularly they affect the NM type of receptors. Now what is the problem when we have the antibodies, when we have the autoantibodies against NM receptor? To understand that, let me draw the neuromuscular junction. So this is the nerve and this is the muscle. Yeah. Now we know that whenever the action potential comes, the sodium enters. Now along with that, the calcium enters. And there is storage of acetylcholine in the vesicle, and that will get fused and there is release of acetylcholine. The release acetylcholine acts on the receptor called NM. This is NM receptor. This is NM receptor. Now when the acetylcholine acts on NM receptor, this NM receptor will responsible for skeletal muscle contraction. That will cause skeletal muscle contraction. So normal physiology, remember when sodium and calcium enters, the acetylcholine fuses and releases the vesicle fuses to the presynaptic terminal, and the acetylcholine is released, which acts on the NM receptor, and you see skeletal muscle contraction normally. Now what happens in a patient with myasthenia gravis? The problem is thymus. So in certain people, thymus is active, and thymus contains the muscle cells, and because of that, the muscle cells also contain the nicotinic receptor, that is NM. Because of that, the nicotinic receptor acts as an antigen, and thymus starts producing antibodies towards nicotinic receptor. So thymus starts producing antibodies, and these antibodies will come and attack the nicotinic receptor. Not only that, there is activation of complement system. Complement pathway gets activated, and that is also responsible for triggering this antibody induced reactions. So these receptors are not going to be working because the antibodies are going to kill them. But there are certain receptors which are not attacked, they are still working. So the problem is whenever the acetylcholine release, it cannot produce a full response. So as the day progresses, the muscle weakness increases. Now you know the pathophysiology. Now tell me what should be done. And remember, the acetylcholine is metabolized by the enzyme, and the enzyme name is called choline esterase, and it is split into acetate plus choline. Now tell me, what should be done? Number one, what we can do is increase the stay of acetylcholine so that the remaining receptors are activated and the muscle will function normally. Now we cannot give acetylcholine in the treatment because acetylcholine is very short acting. It is working only for 5 minutes. So how do I increase the acetylcholine activity? By inhibiting the enzyme choline esterase. So the drugs which inhibit the enzyme choline esterase, they are called as anti-choline esterases. They are called as anti-cholinesterase drugs. So that is the one we can do it. So give anti-cholinesterase drug. Apart from that, the problem is the thymus. Now certain people in young patients, if the patient is young and a patient who have thymoma, these patients you can do a surgery, remove the thymus by doing surgery. So that is the second therapy what we can do. Do the surgery. So that is the second target. Now the third important thing is when the antibodies are more, you can remove the antibodies by a process called plasmapheresis. So we can do something called plasmapheresis. Now it's an immunity. It's an autoimmune problem. So what you can do is, number 4, you can use immunosuppressants. You can use immunosuppressants. So what are the immunosuppressants what we use in the therapy of this? They are nothing but corticosteroids. So they are corticosteroids. So commonly prescribed one is prednisolone. So we can give prednisolone corticosteroid. Apart from that, we can also use azathioprine and cyclosporin and a monoclonal antibody, and that is called rituximab. So rituximab is a monoclonal antibody. It targets CD20. So it's a blocker of CD20 and the name is called rituximab. So the commonly used steroids are prednisolone. So there are 4 important therapies if you see here. Number 1, you can give anticholinesterase drug, and number 2, do the surgery. Number 3, do plasmapheresis. Number 4, use immunosuppressant. Now I told you there is activation of complement pathway. Now you can also suppress that complement pathway. Another new drug is used for myasthenia gravis, and that is called eculizumab. So eculizumab is a mAb which inhibits cleavage of C5. So if you inhibit a cleavage of C5, the complementary pathway is not activated, so the autoimmune process will be decreased. So new drug approved for myasthenia gravis is called eculizumab. So these are the modalities of treatment for myasthenia gravis. But let us discuss what are these anticholinesterase drugs used for myasthenia gravis. Now the anticholinesterase drug commonly used are, number 1, it is called neostigmine, and one more drug is called pyridostigmine. So we use neostigmine and pyridostigmine for the treatment. Now the comparison of the two drugs, pyridostigmine is longer acting compared to neostigmine. So if you want longer acting, then you can prescribe the pyridostigmine drug. Now where do we want the action? We want the action when the acetylcholine increase, we want the action of acetylcholine in NM junction, but you cannot tell it to work only on that. So many a times it will act on muscarinic and patient will have muscarinic adverse effect. So how do you take care of muscarinic adverse effect? Block that muscarinic receptor, and who will block that? And the drug is called atropine, or you can use atropine substitutes. Or you can use atropine substitutes if the patient develops muscarinic adverse effect. So then you will only get the NM action and the muscle improvement occurs. So the drugs used are neostigmine and the drug is called pyridostigmine, and we want the action to be in NM. We don't want it in muscarinic because muscarinic actions, it will cause excessive salivation, excessive secretions, all those things. So don't want give atropine or atropine substitute which will block the muscarinic receptor. That can be done. So these are the modalities of treatment what we do for myasthenia gravis. Now one more important application they will ask you is, suppose a patient with myasthenia gravis, he develops an infection. He develops some gram-negative infection and a doctor gave him aminoglycosides. So aminoglycosides are antimicrobials, particularly used for gram-negative infection. Now what happened when the patient has myasthenia gravis and he has an infection and we give aminoglycoside, the muscle weakness worsened. Muscle weakness worsened. Now what is the reason why it worsened? The reason is simple. You know the synapse. This is the synapse. This is the muscle. Now what happens? The calcium enters, and once the calcium enters, we know the vesicle will come and fuse. Acetylcholine is released. It acts on the NM receptor. We see the contraction. But when we use aminoglycoside, I will write it as AGs, they block the calcium entry and there is no release of acetylcholine, so they will cause neuromuscular blockade. And you know that already there is problem in neuromuscular conduction because of NM receptor having autoantibodies, so they will cause neuromuscular blockade. The question is, aminoglycosides should not be used in a patient with myasthenia gravis. Remember, these are contraindicated in a patient with myasthenia gravis because the muscle weakness worsens. So that is one clinical based application they can ask you. Clear? Sir, we understood the drug therapy of myasthenia gravis, but how do you diagnose? Now the diagnosis is also done by certain drugs. How do you diagnose myasthenia gravis? Diagnose myasthenia gravis. For that we have a shorter acting drug. The name is called edrophonium. And we have discussed about this drug in the previous cholinergic videos. Edrophonium is a drug which is used to diagnose myasthenia gravis. And what we do is we give 2 mg of this and see whether the muscle weakness improves. So we give it IV and we see the muscle, whether the muscle weakness has improved or not. Yes or no. If it is not improving, we will wait for another 30 to 60 seconds and then we give another 8 mg of edrophonium. Now when we give edrophonium, what happens? The muscle weakness improves. So if the muscle weakness improves, then we diagnose it as a case of myasthenia gravis. The reason is edrophonium is an anticholinesterase. So it will increase the activity of acetylcholine. When the acetylcholine levels are more, they act on NM receptor and the muscle will contract and the weakness will be improved. So that is why. Why do you use edrophonium only? Because it is shorter acting and the name of the test is called tensilon test. Now why do we call it as tensilon test? Because when the edrophonium was introduced for market, the brand name of edrophonium was tensilon, that's why they have kept the name. Are we still using that? No, it's only historical importance, but for MCQs it is still being used. What the drug used for diagnosing myasthenia gravis is edrophonium. So we give 2 mg IV, we check whether the muscle weakness improves. For example, patient has ptosis. After giving edrophonium, the patient should be able to open the eyelid. Now, then after 30 to 60 seconds, we give another 8 mg and see whether the muscle weakness has improved. If it has improved, obviously it is myasthenia gravis, not other muscle dystrophies. Now, many times what you do is we have a test called provocative test. So, provocative test is a test where we provocate. The name itself is provocate the myasthenia gravis. So, the drug used for that is D-tubocurarine. It is called D-tubocurarine. Now, the problem here is Now this is the neuromuscular junction, this is the nerve, this is the muscle. Now what happens? This is the receptor NM, NM, NM and NM. So let us assume the antibodies have blocked this and acetylcholine is not able to fully function. Now when we give D-tuberculin, let me write it DTC, it's a competitive blocker. It will also come and block the remaining receptor. Now when it blocks remaining receptor, what happens? The muscle weakness increases suddenly. And this test should not be done unless you are in ICU or you have ventilator support, because patient may go for acute muscle weakness. So this is outdated test, so provocative. So when you give D-tuberculin, the muscle weakness worsens further, then it is also diagnostic of myasthenia gravis. These are all only historical importance. So nowadays what they are doing is they are doing anti-nicotine receptor antibody assay. So that is what is being done nowadays to check for myasthenia gravis. Right. So another important application, what we need to understand is, now when we treat a patient with myasthenia gravis, sometimes we may give high dose or low dose of the drug. So we have to vary the dosage. For example, patient is taking pyridostigmine. After a few days he comes and tells, sir, I have weakness. Should I increase the dose or decrease the dose? How do I know it? The problem is here. The problem is when the acetylcholine is less, it cannot act on NM receptor. So the weakness occurs. The weakness occurs. Even when the acetylcholine is more, it acts on NM receptor. Now what happens when you stimulate a receptor repeatedly? Particularly the nicotine receptor undergo rapid desensitization. So they undergo rapid desensitization. So because of this repeated depolarization, the muscle weakness occurs. So weakness of muscle occurs. So let me write it as muscle weakness occurs. So how do I know whether the patient what we are giving the dose is lesser or higher? Now if the dose is lesser, the muscle weakness, what happens is called myasthenic crisis. So myasthenia crisis. If the dose is higher, the name itself is telling you are giving excess of cholinergic system. So it is called cholinergic crisis. Cholinergic crisis. So if acetylcholine is more, it will lead to cholinergic crisis. The reason is it will bind to the receptor, repeatedly depolarize the muscles, and the receptor will undergo desensitization. Again the muscle will get paralyzed, so weakness. If the acetylcholine is less, the NM receptors are not stimulated, the muscle weakness will occur and myasthenia will worsen, that is called myasthenic crisis. Now how do I differentiate this? Whether the patient has myasthenic crisis or cholinergic crisis? Again, for differentiation, we use the drug by the name edrophonium. We use the drug by the name edrophonium. We give the drug intravenous. Now when I give edrophonium, what happens is it will increase the acetylcholine activity. It will increase the acetylcholine activity. Now what happens if the patient is having myasthenic crisis? If the patient is having myasthenic crisis, what happens? When you increase the acetylcholine, now you check here. What is the problem here? Decrease in acetylcholine. Now when I give edrophonium, the acetylcholine increase. What happens to the myasthenic gravis is the muscle improves. So the muscle weakness improves. The problem here is decrease in acetylcholine. So muscle weakness improves. Now in the second situation, if the patient is already having cholinergic crisis, and if you give edrophonium, the acetylcholine level increases. If he already has cholinergic crisis, the acetylcholine increases, and what happens? You are already in cholinergic crisis, you can see acetylcholine is high, and you are adding more acetylcholine. So what happens to the muscle weakness? Muscle weakness worsens. Muscle weakness worsens. It will become worse. So this is the reason why you have to differentiate myasthenic crisis as well as cholinergic crisis, and what we use is a shorter acting drug, edrophonium. So simple. If the muscle weakness improves, it is a myasthenic crisis. That means you are giving a lesser dose of pyridostigmine. So increase the dose. If the muscle weakness worsens further, that means you are giving overdose of pyridostigmine and you are increasing the acetylcholine more. So reduce the dose of pyridostigmine. That is the application why we do hydrophonium test. Right? So I will just summarize the thing. For example, you are giving pyridostigmine for the management of myasthenia gravis. So should I know whether the dose is correct or not? Yes, that depends on hydrophonium test. If the hydrophonium test, if I do the muscle weakness improves, let me write like this. If the muscle weakness improves, then you have to increase the dose. If the muscle weakness it becomes worse, then you have to decrease the dose. So this is the application what we understand by the differentiation between myasthenic crisis and cholinergic crisis. So that is about the drugs used in myasthenia gravis. So it's an application of the ANS pharmacology and it can be asked as a case-based question to you. So please remember, it's an autoimmune disorder and the antibodies are produced against NM receptor. So what we need to do is we need to increase the activity of acetylcholine and we use anticholinesterase, neostigmine, pyridostigmine. Along with that, you can do thymectomy, plasmapheresis, and you can use immunosuppressant, particularly corticosteroids. New drug is eculizumab. It inhibits the cleavage of C5. Now, when we have to diagnose myasthenia gravis, the drug is called hydrophonium. It is called tensilon test. Hydrophonium is also used to differentiate two crises, myasthenic crisis, cholinergic crisis. When you give hydrophonium and worsens, it is cholinergic crisis. If it improves, myasthenic crisis. That's it from this video. Thank you all.